Good morning. Welcome to our first ever Child Mental Health Summit. It's going to be an exciting day. I'm John Nickens, CEO and President at Children's Hospital here in New Orleans. And welcome. It's my pleasure. All of you guys that are live streaming, good to have you here. Welcome to our expert and panelists and speakers that are here with us today. I'm excited about what today means, and I want to start off with just pausing and being purposeful. And we're coming together to make a difference. We view this as the opportunity to be a catalyst. And today, Children's Hospital, our city partners and state officials, we are declaring a mental health crisis in Louisiana for our kids. We know they're suffering from depression, anxiety, the thought of suicide at alarming rates. And today is an opportunity. It's time for us to respond to that cry for help. You know, you look at the statistics and they're staggering, sometimes overwhelming. Last year was a tough year, our COVID year. If you look at emergency room visits for mental health, last year they bumped at every children's hospital in the nation. If you're in the age group of 5 to 11, it went up 24%. If you're 12 to 17, it went up 31%. And the end of the year last year, we had a 17% increase in kids attempting suicide or self-injury. I think we have a crisis. What I'm excited about is we have some people here that are going to help us navigate that. We're going to have a discussion. We're going to talk about ideas. We're going to come together as a group and as a team. And at Children's, we refer to that as being extraordinary together. What can that look like? How can we work together? I hope that today is a catalyst for action. I hope it brings us together. I hope it re-energizes many of you who wake up every day fired up and use your diverse and unique skill set to fight the battle, the challenge of mental health. You know, we refer to this extraordinary together, and you think about it, how can we be extraordinary together? What you're going to hear a little bit about today is really just the idea of coming together and the value that brings. We can put resources, we can put experts in the right places that changes the dynamics. Our kids can be healthier. They can have a brighter future. I would even say to some degree they can get their life back. We can create those stable moments where our kids, our next generation, our future Louisiana citizens are healthier, and they're extraordinary. You know, the idea of caring for kids holistically, certainly at the hospital, we think about their physical health, but we have to move beyond that with emotional, spiritual, and the mental health. And today is a critical moment for us to pause and, as a group, work together on changing the dynamics. I want to say thank you to the audience for taking a moment and joining us. Thank you to the experts and panelists. We appreciate all of you being here. I get the privilege to introduce our welcome panel. Jonathan Brook, over to my left, will be our moderator. He's our Chief Operating Officer. Thrilled to have him here, and the service line of behavioral health is his responsibility on a day-to-day basis. Dr. James Hussey, we're thrilled to have you here from Louisiana Department of Behavioral Health, thinking about our entire state and kids and the challenges they wake up with every single day. Dr. Tony Gross, our Chief for Emergency Medicine. In a few minutes, we'll hear from Dr. Ron Bailey. He's the department head for LSU Health Science Center here in New Orleans. He'll have some comments to share for us. But my real enthusiasm for today is to welcome Mayor Latoya Cantrell. And Mayor, I want to say thank you. Over the last year and a half, you have made the hard decisions. You have been tough. You have done the right thing for us as the citizens of New Orleans. You've kept us safe. And thank you for your passion for kids and for families. We feel it, and we work hard every day to match it. I'll turn it over to you now to speak. Thank you. Welcome.
Thank you. Well, I too welcome you this morning. Thank you so much to the Children's Hospital family as I see it. And under your leadership, John, It's been transformational, and I appreciate that. And transformational in a sense of really being holistic for all of our children, regardless of where they are, but the ability to meet them exactly there and their families as well. So I appreciate that. To our panelists, those who are here, and those who you will be hearing from throughout this afternoon, thank you so much. You know, when John mentioned that we have a mental health crisis for our children, he's spot on. And I'm hoping that today will be catalytic in our holistic approach to meeting the needs of our young people. The thread of mental health really has been something that I've focused on overall. So whether that was, president of the Broadmoor Improvement Association, rebuilding our community after Katrina, ensuring that and knowing that behavioral health was vitally important in terms of a recovery. So we brought in and hired a licensed clinical social worker to set up case management for people. Then, of course, getting on the New Orleans City Council, making sure that health and public health was a priority, but partnering with children to reestablish adolescent care, focusing on mental health. And thank you again. And what we have now, we know, is far more and much more than we had previously. But we have so much need in our community and throughout, of course, the state of Louisiana. As a mayor, coming in and establishing a meditation room, something that may sound so simple but definitely needed, not just for employees, but for residents who are coming to seek services from the city, but needing to kind of calm and cool it down. From establishing the first ever mayor's office of youth and families, again, that holistic approach, because that need is so vitally important. And of course, here, even throughout this pandemic, having the Mayor's Youth Advisory Council really produce their own focus on a mental health town hall that they spearheaded and engaged experts from around the city as well as state to speak to their needs that they said that they were having trouble with, of course, over the past 16 months or so. And that's growing because now we're segueing right back into school. But when I think about the state of Louisiana, with 55% of our youth having major depression and do not literally receive adequate care, that means we're in a crisis. As John mentioned, that most mental health conditions are detected right around the age of 14 years of age, but at the same time, they go undetected and even untreated. It's also very troubling, with the intentional self-harm and how that impacted our young people even over the past year, with us leading like the #1 cause of death between our youth ages 10 and 24. We're in a crisis. 2020 alone, and John kind of touched on this, but 46,000 of our children reported having one major episode in terms of depression. But what's even more shocking, 54% of those children did not receive any treatment. We're in a crisis. So today we know that we are facing a tremendous shortfall in services that are available, and we have to do something about it, but being comprehensive and holistic in our approach. Now, I am here and present just to ensure that the city of New Orleans, that I make this commitment on behalf of the city, that we are going to partner every step of the way, leverage resources that we can bear to bring to the table, because the time really is now. So although, we're already, of course, partnering with Metropolitan Human Services District, we're collaborating with them where we conduct a school behavioral assessment every single year so that we collect that data, but also analyze that data to be able to meet the needs of our young people. From also partnering with UMC in terms of their behavioral health emergency room so they can analyze the data that they're receiving there, so that, again, hopefully this can factor into opportunities of care that we can create together. Of course, the expansion of the low barrier shelter in the city of New Orleans is happening now, but with and through a greater lens of coordination of care, greater coordination of care, and folding in that mental health services. It has to be front and center. We know that even with our summer programs, that it's embedded in NORD, in our libraries. Even when I think about the Juvenile Justice Intervention Center, that was a tremendous gap coming in with the lack of care that we were giving to young people that were in our care in the detention center. But thank you so much, John, for strengthening that relationship with children, because there was once a time that kids that were in our care in the detention center were not even being seen and even turned around because they were system-involved youth. But if we're really talking about a crisis, we're talking about all of our children. And especially when we know that we say public safety is a priority, public health is a priority. But here we are right now with our children leading as it relates to this Delta virus in this pandemic, when we were giving those warning signs a year ago, but here we are. Even when we talk about public safety and the issues that we've seen from our young people getting involved in violent crime, here we are. Even when we think about the suicides that happened in our community last year of our young people alone, here we are. So what I want to say and what I want to also just kind of put out there, and I spoke about this when you all were working on coordinating this, I really wanted to focus a little bit on the social media aspect and the impacts of social media on mental health as well. And also, I want to challenge our school systems and our charter management organizations. So when you take on initiatives annually, that week of mental health or that week of suicide prevention, but when you look at that from last year alone, what followed? Multiple suicides among our young people in this community and throughout the state of Louisiana. So I think that we need to rethink how we even address or approach this with our young people, because what we did see was a rise, and also what we saw, and when I'm there at funerals, burying young people, or with parents who are burying their children who have committed suicide, and only to reflect on those cell phones, the messages, the bullying, and somehow the sense of security using technology to damage people. And our children are people. So I thank you for allowing me to be here. And listen, I'm so passionate about this, but I'm so committed as well. So again, you have all of me as it relates to our young people and families in this community and throughout the state of Louisiana. So thank you again.
Thanks so much for those remarks. My name's Tony Gross, and I'm the director of the emergency department at Children's Hospital New Orleans. I'm so happy to be here with you guys today. I can echo what you've already heard from Mr. Nickens and Mayor Cantrell. The emergency department is acutely aware of the mental health crisis in our community. During a 6-month period, over last fall through spring, our emergency department treated over 1,500 patients for behavioral health concerns. And this volume is a significant increase over our pre-pandemic census. We are currently bracing for the seasonal increase in demand for mental health care in the emergency department that usually accompanies the start of the school year. And as mentioned earlier, starting back to school this year may be especially stressful to students who were out last year. Emergency departments and trauma centers are busy places, and we have strived to make that environment feel less hectic to our patients and families. Several initiatives have allowed us to form a team approach to mental health care provided in the emergency department. With the opening of the new main campus emergency department this month, we will have a behavioral health pod that is specially dedicated to providing a break from the fast pace of the rest of the emergency department. In addition, we are adding behavioral health clinicians to help us provide the expert care that extends out from this beautiful facility that we're next to, that opened just a little over a year ago. But even with these initiatives and additional resources in our emergency department, we know that more is needed. The emergency department is the safety net. It is there for patients in crisis, but it is not the site where most patients and families desire to receive recurring care for subacute or chronic mental health conditions. Early recognition and intervention are key to successfully combating this crisis. But we stand firm with this community in being that safety net. and want to be good partners with our patients' medical homes as well as their schools, where we know they spend the majority of their waking hours. So thank you to everyone who's joining in this effort.
Thank you. My name is Jim Hussey. I'm the Medical Director for the Louisiana Office of Behavioral Health. It's really a privilege and a pleasure to be here and speak with you guys today about these very important topics. You know, I've been working in our state system for over 30 years, and during that time, I've seen a lot of challenges, but I've also seen a lot of positive changes. You know, of course, the COVID-19 pandemic has introduced additional stressors to everyone, particularly our youth and our families. Everything from isolation from school, disruption of daily routines and activities, disruption of peer relationships, unemployment of parents, housing and food insecurity. All of these have put major stress on our youth and our families. And you might imagine also that when you add health disparities, poverty, structural racism on top of this pile of stressors, even more negative impacts on the youth and families in our state. According to Medicaid data that I looked at prior to coming here, between 2019 and 2020, almost 25% of youth from certain disadvantaged areas in our state had mental health diagnoses. Students and families in each of these communities really had very limited access to mental health treatment in those communities. In fact, according to a Louisiana CDR report that covered between 2016 and 2018, so of course that's pre-pandemic, about 8 children between the ages of 10 and 14 die each year from suicide in our state. That same report indicates that only 1/3 of those individuals and their families received any mental health care prior to their death. Youth with intellectual disabilities, those with severe behavior problems, those who have been traumatized, those in Department of Children and Family Services custody, those who are court involved, have yet even additional challenges and complexities. So we need to put together special care, special treatment, special services, special behavioral health services for these individuals. In response to these needs, we've added many new behavioral health services over the years, at least since 2012. We still need to add more and provide greater access. Beginning in 2012, in Medicaid, we added substance use disorder services. Believe it or not, prior to 2012, Medicaid did not cover substance use disorder services in the state of Louisiana. Prior to that time, we also had very limited access for various professionals to deliver specialized behavioral health services. Around that time, we opened up Medicaid and reimbursement and services to psychologists, certified nurse practitioners, licensed clinical social workers, licensed professional counselors, licensed and marriage family therapists, and licensed addiction counselors. We also added new services for children, like therapeutic group homes and psychiatric residential treatment facilities. We also added a wraparound service called Coordinated Systems of Care, CSOC, and those services were targeted particularly for individuals with severe emotional disturbances. Since that time, we've served over 19,000 kids with that service, 73% of which have shown increased functioning, decreased problems with school attendance, and their families have shown decreased stress, measurably so in the outcome data that we look at. In 2014, we added applied behavior analysis for individuals, for kids with autism spectrum disorder. And since that time, we've served over 5,200 youth with that service. Again, in 2014, we added multi-systemic therapy, an evidence-based service for kids with behavior problems. And since that time, we've served over 8,700 individuals with that service. That's an evidence-based service in which people who get that service, 96% of the kids remained in their homes and out of detention. 94% remained in school and had no new arrests. So you can easily imagine, without services like that, many of these kids may have wound up in detention and separated from their families. We've also added Medicaid reimbursement for evidence-based practices like functional family therapy, FFT child welfare, and home builders. In fact, since 2015, there's been a 48% increase in the number of children receiving evidence-based practices in Medicaid in Louisiana. Still far from adequate. We need to really push and incentivize and resource those services. In fact, outpatient mental health treatment delivered by licensed practitioners and psychiatrists grew by 80% since 2015. Still not enough. While we've seen some recent dips related to COVID, particularly in the first quarter of 2020, we are seeing kids get back to services. Providers are using telehealth, and gradually, hopefully Delta virus won't trip us up further, but we're gradually seeing more people get face-to-face services again. In June 2018, I'm proud to say that we got into a collaboration with LSU Health Sciences Center, the School of Public Health, and we launched the Centers for Evidence to Practice. That center supports dissemination, education, and training around evidence-based practices. Evidence-based practices like parent-child interactive therapy, youth PTSD, and preschool PTSD treatment. And again, these are important services. We still don't have enough resources. Payment is probably not enough to attract and keep enough providers, so we need to do more in that. But these are critically important services. All these EBPs, evidence-based practices I mentioned, are just critical, and they help improve symptoms, kids and family functioning, and they help preserve, and in some cases, reunify families, and families are very important to preserve and reunify. I mentioned intellectual disability and DCFS earlier. We continue to partner with the Office for Citizens with Developmental Disability, OCD. We try to recruit and train more individuals who are competent and trained to treat those who have both behavioral health and intellectual disabilities. We also work hand in hand with the Department of Children and Family Services. A lot of their youth are very traumatized, neglected, in many cases abused. So we continue to work with them to try to improve access to necessary behavioral health services. So again, even with all of these enhancements, it's still not enough. Some of these families, many of them, still need more. So what's next? This is a short list. There's plenty more we need than I'm getting ready to list. But number one, we need more focus on early childhood prevention, intervention. We need to continue to increase and incentivize evidence-based practices like the ones I mentioned. We need to invest in mobile crisis. We need to serve these kids earlier where they live so that they don't need to go to emergency rooms or hospitals or risk being taken out of their homes. We need to work harder with DCFS and others to recognize, prevent, and treat trauma. We need to support DCFS and the Office of Juvenile Justice more. We need to keep those families together, keep kids out of detention, keep them in their homes and communities. We also need to work together to understand how the social determinants of health, how health inequities, structural racism, structural stigma affect our youth and families. I do want to say finally that perhaps one of the most important things we can do today for our youth and our families is get vaccinated for COVID-19. That is something that is critical. And so I really want to encourage everyone to get vaccinated. Whether you're vaccinated or not, I also, on behalf of the Department of Health, want to encourage people to wear masks, if they're particularly indoors, and if they're unable to stay 6 feet apart from other people. So with that, I really, again, want to thank you for the opportunity to share this information with you, and I really support the efforts and everything you guys are doing. Thank you.
Okay.
Hello, I'm Dr. Ron Kennedy Bailey, Chairman of the Department of Psychiatry at LSU School of Medicine here in New Orleans, and Assistant Dean of Diversity and Community Engagement. Welcome to the Children's Hospital of New Orleans annual program. I'm new here. I started 2 months ago, June 1st, but I'm very excited about joining the LSU family and the Chinola family as we work together in this attempt to take care of patients, children, and adolescents with various forms of medical and psychiatric disorders. In my background, work in children's settings has been very important. I myself worked here about 2 decades ago at the NOAA, the Adolescent Hospital in New Orleans, caring for individuals with clinical depressive illness, other forms of affective illness, psychotic illness, bipolar disorder, and otherwise. That experience really it ingrained in me the need for highest quality patient care throughout our New Orleans community for our children and adolescents who are in need. Now, the LSU School of Medicine has grown exponentially. We have over 50 full-time faculty across a full array of clinical services in child psychiatry, as well as in addiction, in forensics, and geriatrics, and in consultation and liaison work, meeting really all of the challenges that children and adolescents meet and come with requiring psychiatric care. It's also important that our department works with individuals throughout the full array of geographical areas and services throughout New Orleans. We're also at the VA hospital, at the University Medical Center, in Truro, and others. So our historical legacy of working in the charity hospital and taking care of all patients remains our mission, remains our challenge, remains our responsibility going forward. It's also important to note that we have a department with excellent morale. Individuals who really want to be here, who are dedicated and committed to caring for patients. I think in this community, really finding ways to meet very often the unique and very pressing, very severe challenges that our local community has to offer. Going back to the Katrina hurricane problem of a decade and a half ago, we've dealt with trauma for children, infants, children, adolescents for many years. We also, I think, addressed issues regarding violence and other forms of neglect and abuse. All issues that, although difficult to discuss, are our responsibility to find ways to meet, I think, that challenge of caring for our patients. It's also important that we have vision and that we grow. I'm interested in bringing a repetitive transmagnetic magnetic stimulation machine here to address patients who may be treatment resistant and who don't fully get to the point of remission of all illness if they have clinical depressive illness over time. So finding ways to treat all patients, finding strategies that really address the most recalcitrant response, and finding ways to really partner with families and communities for a best-in-class management approach will be our challenge and our responsibility and our strategy going forward at Institute of Medicine New Orleans. We ask you to join us in caring for our patients. Welcome. I'm thankful for my ability to be part of the team and looking forward to really great work here at Chinola and LSU going forward. Thank you very much and have a good day.
Wow. Thank you to our welcome panel, Mayor Cantrell, John Nickens, Dr. Gross, Dr. Hussey, Dr. Bailey, who joined us by video. We really thank you for the work that you're doing to address and improve the significant needs of our community. Thank you again for your commitment and incredible insight. We really do have an all-star panel of experts to share with you today, so we're going to keep things moving right along. Our first focused panel of the summit is called The State of Child Mental Health in Louisiana. This is a two-part segment. We're going to start off first with a recorded video message from Chantel Reed, Deputy Director for the New Orleans Health Department, and then it is our honor to introduce Karen Evans, Executive Director for the New Orleans Children and Youth Planning Board, who will discuss the city's youth master plan. Please turn your attention to the video.
Good morning, Mayor Cantrell, Mr. Nickens, and everyone in attendance. Thank you for the opportunity to address the state of child mental health in our city and state. According to the CDC, 1 in 6 children had enough symptoms and impairments to meet the criteria for one or more childhood mental disorders. Annually, our health department's Behavioral Health Council conducts a school-wide behavioral health assessment. In the 2019 report, it was estimated that 2/3 of children who access behavioral health treatment do so only in schools. When we look at a school setting, counseling staffs are limited in the services they can provide. In a clinical setting, our providers are stretched to provide services to those in the most dire need. It was clear, even back then, that for many years we have struggled to meet the growing demands of behavioral health needs in our community, especially for our children. Prior to joining the health department, I led a behavioral health clinic in the greater New Orleans area. I saw firsthand the delays in access to care. The main contributing factors were availability of providers, coverage, and transportation. In order to address some of these factors, we have to start with more providers willing to accept Medicaid patients. I have seen patients in acute crisis wait for days in the emergency department because there were no available beds. It is disheartening to see families with limited resources struggle to travel as far as Shreveport because there's no care in the greater New Orleans area. To support providers with accepting all patients, we must ensure adequate coverage of services, especially for those patients with Medicaid. Transportation is another one of those components of the social determinants of health that we cannot disregard. If families cannot travel to be with their children during their times of greatest need, we are doomed for failure. We must support families in addressing social determinants of health to even meet their behavioral health needs. Let's rewind to March 2020 with a sudden transition for all students to the at-home learning environment during the pandemic. Many underlying behavioral health issues were exacerbated, even in children without prior histories struggling to cope. Schools, providers, and parents were required to immediately pivot to the virtual learning environment. This environment was plagued by inadequate social needs and compounded by a fear of an unknown virus. Our children watched as we struggled to make sense of the unfamiliar and sometimes with limited tools for support. Those with mental health disorders oftentimes went weeks, even months, without access to care. As providers and educators scrambled to provide solutions, laptops, Wi-Fi, telehealth, those who were most impacted economically, especially our Black and Latino children, searched for basic needs, the next meal, electric services. Even children in healthy environments, being at home for long periods of time and disconnected from friends, were severely impacted developmentally and emotionally. The Louisiana Public Health Institute review of COVID-19 in the greater New Orleans area showed that 83% of behavioral health providers in our areas shifted to telehealth services. While we have worked to be able to expand these services for years, our children have indicated that they need in-person direct care. As public health professionals, I can say that we have seen the impact and have worked with providers to provide the response to the pandemic. It is critical to the long-term development of our children that we do all that we can to return them to a safe, supported environment with services they need to remediate the uncertainty of the past year. Our presence at this summit shows that we have the tools and drive to move the needle forward in behavioral health for the children in our community. Now, it is incumbent upon us as citizens to do our part, vaccinating, masking, and encouraging others to do the same. I trust that the behavioral health providers here at this summit will address many of the needs that we have as far as behavioral health disorders. We can all do our part with the pandemic and supporting our children's needs. We thank you as the health department and the support in that process.
Good morning. Good morning. It's good to be in person with some and virtual with others. My name is Karen Evans. I am happy to be here. And yes, there is a child mental health crisis in New Orleans and thereby in the state. And so my time with you today is to sort of chat about that from the chair that I get to occupy. In the New Orleans Children and Youth Planning Board, we've got a couple of things that are moving parts that we believe are part of the work towards solution and coordination and partnership that's necessary in our mind across sectors to move work forward to advance the well-being of our children collectively. And yet I feel like the start of this conversation from my perspective warrants a little leveling of sort of a grounding of what we are meaning and what that meaning looks like on our landscape. So first, let me just offer my thank yous. This extraordinary moment to talk about this extraordinary issue from the Children's Hospital. Putting this together, this critical conversation together, is the start point of what I'm hopeful will make differences in the way we go forward to address the issues that are going to be surfacing further today. I appreciate the partnership that exists between Children's, the City of New Orleans Health Department, and the Louisiana Department of Education, that together, those three sectors and operating peoples and organizations can stand for coordination and for systems change and supports for the children of Louisiana. Now, while I'm representing New Orleans, you'll hear my bias because that's the part I know. This really does play out for children in other places and spaces as well. So let me just start by starting with the question, which for me is the question around the state of children's mental health in New Orleans. and it sort of grounds our conversation today. The question is, and how are the children? And I ask that question because that's a question that's often referred to in group collective impact work around children's outcomes and efforts. That question is really coming from the Maasai tribe in Kenya, who asked that question warrior to warrior when they greet. And how are the children? And the answer should be, all things good, that all the children are well. That's our aspiration. And so I offer you that as our start point because we need to get some meaning around what we are looking at. So in the Maasai tradition, the meaning of all children are well is that peace and safety prevail on the land. And so when I think about the things that we hear that present problems and challenges to our children and their families, peace and safety represent an ingredient of hope that we need to address, right? In the Maasai tradition, community priority shows up that protecting the young is the priority of every community member in the community. And I don't know if we can demonstrate that level of commitment from birth to 24, but that's what we need. This crisis is calling for the commitment of every community member. And then the further meaning is that all the children are well means that life is good, that daily struggles for existence do not preclude the community's commitment to caring for the young. There will always be moving parts, but our investment and commitment to caring for the young does not move away from supporting and moving that forward. It's not optional. It's not tentative, and it's not political. So with that as our definition, I want to just remind us that while we are not the Maasai, we carry a good deal of those replicated positions, and they show up, the CDC sort of frames what child mental health looks like this way. They say being mentally healthy during childhood means reaching developmental and emotional milestones, and learning healthy social skills, and how to cope when there are problems. Mentally healthy children have a positive quality of life and can function well at home, in school, and in their communities. Now that, for me, is a direct overlay in our translation of a community that supports and builds support systems for the children because children are centered in it. Not sure we're there yet, but that's where we're going. So let's talk about who by children we mean. Now for our work, we're talking about children ages birth to 24 years. And so I want to look at the population to make sure we're talking about the right numbers, because sometimes when we talk about the need, we don't look at the volume we're really needing to assess, and are we matching that with the appropriate supports and services. So in New Orleans, our population is 390,144. This is from census and from data center. This is our total population. 25% of that population is children, birth to 24 years of age. That means 97,536 children are part of the city's population. That's a lot of folks, 25%. And yet 75% of our population could be available as the community that lifts up, supports, protects, and holds safe our children. Of the 95,536 who are children birth to 24, the CDC, and I think Chantel mentioned this, but the national average for children who reflect a need for mental health services is 1 in 5. 20% of that population. So for us, that's 19,507 every day, any day. Do we have the capacity to attend to 19,507 children in this city, ranging from birth to 24, using and needing different levels of care, needing to be caught up at the front end in the prevention space, needing help at the early intervention space, needing deeper work in the depth of prevention, and intervention doesn't work? How do you get into deeper intervention services? How do we coordinate and connect all of those services so that there is a fluid line, a coordinated expression of care? How do we make sure that our offer is complete, that we don't lose children along the journey? How can our community say all our children are well? How do we invest so that that statement becomes true? Well, I want to talk a little bit about the two parts of this work. For me, there is a treatment part, the presentation of how we build the treatment continuum, how we ensure that it is quality, it is prepared, it's scoped, ready with evidence-based practices, and we've got all of the levels of care laid out in ways that are accessible, that are sensitive, that are centered on the youth, child, and or family. That's one side of the treatment. But the other side is what caused the need for treatment in the first place. So what are the issues that present to our children, youth, and families that cause them to have mental health concerns? Well, you heard some of them today already. We know what they are, and yet we're not really looking at that as part of the solution, and we've got to do it. We've got to prevent the folks who are not suffering from mental health needs from ever needing to get mental health services, right? So in our model, if 20%, 1 in 5 are in line for mental health services, that 19,000 young people needed, then 78,000 are well, just based on our numbers, right? So 80% of our young people are well. This is an approximation, but the model works. And if 80% of our young people are well, how do we keep them well if we are not attending to the barriers and problems and dysfunction that exist on our landscape that cause the 20% to become unwell? This is the toggle that I think we have to marry to treatment. We can't just build a continuum without paying attention to the cause. What was the root cause that brought care into need in the first place? And know that 20% of our young people are waiting for us to get it together. The other 80% are hoping that we hold space for them so that they can remain well. Because at the end of the day, our conversation needs to be about our reality, that all our children are well. And so I want to talk to you about what that might look like. We're going to name and address the root causes. You've heard a little bit about those root causes in a cross-sector way. And typically when we're thinking about mental health for our children, we are looking at mental health as an entity and not about its connection to the other sectors who fold into some of the solutions that could make wellness and well-being rise. So when we think about the causes from the root, we have to remember that we need to include others in the scoping of our work so that we build a sustained effort for change and improvement for young people. And our roots, we heard earlier, we heard suicide, we heard suicidation, we heard about family dysfunction, about poverty, about bullying, social isolation, breakups, social media, substance abuse, discrimination, physical, sexual, emotional, neglect, the host of things that we know to be true that affect our children in ways that cause them to have mental health issues. And what are we doing? Where's our structure and plan to move these things into less impact for our children over time so that while we're building a system that's better, we are also preventing those who are well from being impacted so that they don't become unwell. Those are the two sides of the coin that we really want to address, and I believe that's the work that we have to work on and have been working on in the New Orleans Children and Youth Planning Board. But before I get to that work, I want to just say this, that the Children's Hospital, along with city and state officials, while they have declared a mental health crisis for our children, there are a few issues within our care that warrant an uplift in terms of review. And this conversation says you can point up the ideas around things that need to be attended to. So I've got a few that I want to throw on the table for conversation. The first is that if 1 in 5, if 20% of our youth population are in need of mental health, that's a pre-COVID number. So do we dare to examine what the COVID offer adds? Are we up to 25 or 30%? That's a daunting idea when we weren't able to serve the 20%. So we've got to get our game faces on and figure out what can we do in the space where we had already positioned 20% of our young people in need, and now we've got a COVID expression that has hit them in terms of isolation. Social media has been not kind. Bullying has been going on the internet and the viral ways that has been unkind. disconnected from their social fibers and networks that help them hold wellness, was not there. And now they've got to wonder, do I lose educational traction? I'm starting school, but I had no school for a year. I did it on my own. Mom was trying to help as best she could, but do I have to go back a grade? There may be no truth to that, but that is what's in the mind of our young people. That fear, those anxiety points, all that plays into how we can show up. So we've got 20% of our young people plus the COVID additions that we don't yet really know, nor do we know fully how they're going to show up in space. We will soon, but we don't know enough. And so the emergency room visits may in fact spike, but we go to the emergency room because we don't have fiber on the ground. We heard from the New Orleans Public Health Department that young people want in person. We tripped over into telehealth because we had to. Now the question is, how do we meet them where they need, right? The other area that we need to think about is provider capacity. And capacity means a lot of different things. It means, are we sure that in this lane we've got enough manpower on the ground that has been prepared with enough of the right EBPs that are sustainable and being held with fidelity to the model? Are we sure that we've got enough capacity to address the 19,000, the 20%, the 30%, whatever it becomes? Is that capacity stable? Is there enough resource in the chain to hold those folks in place? With a living wage, in an arguably competitive way? Are they at risk of moving to something that's a little less stressful and pays a bit more? We've got some issues within the capacity space to address. And there is this sustainability issue that we need to address. We need more service, but how do we sustain the services that we have so that they can either expand or increase their ability to do the evidence-based practices that have been discussed, introduced, and proven to work? Sustainability means that the organizations get a better return on their reimbursement rate, that it costs them dearly to deliver service, and when they don't get the full return on what that cost is, we put them at risk for survival. That is a true condition, and we ask them to go find the rest of the money on your own. Find a nonprofit, find somebody else to fill in the gap. Well, the gaps are hurting our children. We've got to figure out how to stabilize the care providers that we have and create ledges of growth so we can expand the service offer to get our 19,000 plus covered with continuities of care. And then we need to make sure we have a complete and interconnected continuum, birth to 24. Right hand hasn't met left hand. We're not connecting around the service delivery systems. There is no way to demonstrate that if you have a need in an early stage of prevention, that you can get that handled and maybe even not need to elevate that lead. But if you do need to elevate, where do you go? Who's on the continuum to offer you support? If you need residential, where does that come from? How are we making sure that there are beds adequate enough to survive the need that we see presenting, the one that we know and the one that's coming because of the pandemic? We've got some continuum opportunities to lay out exactly what exists on the prevention, intervention, and then the deeper intervention side. And if we're not doing that, we're building spaces for our children to fall through gaps. That's not cool, and that means that 19,000, that 20%, are at greater risk because we didn't have a plan to prepare for them. There's two other pieces that I'll offer up, and they are to include prevention and early intervention. We can't just wait till things get so bad that we then start care late. We can't wait until kids get so bad that they've got to go to emergency or they've got to be hospitalized or they get pushed into a juvenile detention or other criminal system because that's where care is. We really have to find a way to build our belief and our investment in prevention and early intervention and do it often, because we can preserve the 80% from ever tipping over. If we do that well enough, we can probably also pull out some of that 20% into an early intervention slice if we had it available to offer, and if we were organized and galvanized to deliver it in ways that reached the young people in meaningful ways. And the last I'll say is that we really do need to stand up for promotion of wellness and developmental stages across wellness. That wellness is an expectation that we should hold for our children, and we have to find ways to promote that throughout the continuum, throughout the developmental stages, because those things matter. Those things help our young people move from the 20% or not even get into that 20% file. All right, so now I'm going to give you some really quick examples of where we're doing work in this area. We're only a small unit of players who are doing some work. We're looking to do that in a collective way, and there are many on our landscape who are doing much work. It would work well for our children and communities if we found out ways to coordinate and collaborate around that work. So I'm going to lay out just a couple of things that we have been engaged with, and I'm hopeful that you'll find that those things really do fold back into the work that I've identified needs to happen. So first, two examples. Call to Care was our response to the trauma crisis that was presented to us in 2019. It asked for a strategy with recommendations to deliver so that we might turn the childhood trauma prevalence that was in our land around. It required an investment, not just in time, talent, but treasure. The treasure investment we still wait for. We have decided to take Call to Care as our approach to trauma and move it towards a sort of a thread throughout our Youth Master Plan. The Youth Master Plan for New Orleans is the first we've ever done, and the Youth Master Plan provides for a host of opportunities for us to connect across sectors to ensure that we are folding in quality care for the well-being of our children and connecting it to places where it gets impacted most. And so I'll share with you just a few things. First of all, the Youth Master Plan, as I say, is now the courier for our Call to Care efforts. And those things are both expressed deeply on our website, so I'll give you that in just a minute. But the Call to Care, the Youth Master Plan effort is partnered in 3 organizations who hold backbone for the Youth Master Plan's movement, implementation, and review. And those organizations are the Children and Youth Planning Board, the New Orleans Youth Alliance, and the Mayor's Office of Youth and Families. So the 3 organizations stand as the backbone to the Youth Master Plan to make sure that it goes forward in ways that align with all the city operations and the community-based strategies that are in play. So what is this thing called a Youth Master Plan? Well, quite quickly and briefly, it's this deliberate, intentional effort to engage in a movement that improves the outcomes of our children across sectors and with them and not on them. It's a comprehensive roadmap centering around positive youth development, a strengths-based orientation targeting birth to 24 children, and ensuring that over the years of the plan, 10-year plan, that we are strategically building actions that touch all the lanes that our children cross. They are in it with us. The combination of youth, community members, parents, families, sector leaders and actors, systems players, all build out what the Youth Master Plan has become. We used a few things to be considering as we were sort of working through it. It's a strengths-based planning centered on young people. It's silo-repelling, meaning we use this approach to make sure we're lifting up cross-sector solutions. We're rooting ourselves in community input, community wisdom, and data. And it's a 10-year vision with actions that span into now, next, and later. It's a systems change process and approach. We need this to last and to stick. There are 6 categories in the plan that allow us to have this cross-sector opportunity, and those are economic stability, space and place, youth voice, agency, and identity, learning, health and well-being, safety and justice. We're looking at those 6 categories in terms of how they impact the individual young person and their family, but also how the environment is impacted by those things. Because what we know for sure is children live in families. We need to plan our approaches that are centered where children are in families and that include the family in the work. We know further that families live in communities. So if we're not doing the work to increase the qualities of issues and efforts represented in communities, we're going to find that family affected again by the things that are root causes, and then we're back at the beginning of our work. Our investment isn't as great as it could be, and it doesn't have the sustaining quality. So we've got to do both, the individual and the community work. We had 3 phases to the process. First phase was coming to the solution space. Second phase was building actions with our sector actors and leaders. We are now in the third phase, which is implementation. Let's get to the work. And so I want to give you an example of one of the categories in terms of a goal that speaks to what we really believe is the way we want to lift up health and well-being for the children of New Orleans. The children, remember, are birth to 24. So for our health and well-being goal, we've stated it this way. We envision a city in which our youth have positive, healthy relationships with caring adults and peers. Youth and their families are aware of and engaged in healthy prevention activity and free from trauma, and have reliable access to physical and mental health care that they need. Our goals are pretty clear. Our current goals are to decrease percentages of young people experiencing exposure to violence, symptoms of depression, substance abuse, PTSD and anxiety, and suicidal ideation. That's our health and well-being track. I give you that example to invite you to go see the other tracks, because we believe that their continuous motion across the 6 categories will give us greater leverage to make the impacts that we believe are necessary to cause the change for our children and youth in this city. The crisis requires all hands on deck. The plan for the Youth Master Plan is to be an all-deck, all-hands assemblage. This is a collective action, collective impact effort for the city of New Orleans. It is a 10-year move. We're taking small chunks of it at a time to ensure our success and our stable movement. And we are measuring, monitoring, and messaging all of the parts of that work forward. You can find out everything you need to know about the Youth Master Plan in a transparent space called our website. NOLAYouthMasterPlan.org is where you will find the details of this plan and all of our expected next movements. NOLAYouthMasterPlan.org. It is also where we would invite you to see our systems of change, our theory of change. And our theory is this, that we live in a current state that has these issues and barriers to success for children, no matter their age, in the birth to 24 lanes. And that those things really do get attention. Often, if they were an iceberg, we'd look only at the top. We'd spend our energy focusing on what was above water. But what's below the water, what sits underneath the surface, we believe are some of the root issues that if we address them, we could get synergy and cause change to be permanent and cause change to be a tipping point for greater leverage. And so we've looked at the mental model work and built solutions that attend to the mental model, what people think and believe. We've looked at the relational level underneath the iceberg and built solutions that are about building greater coordination, about sharing power, about looking at who the partnerships need to include. And then we're looking at the structural parts, which is how do we build policies and practices that lift up the things that we've been changing our belief around and we've been relating differently around. We've done that for every single category, setting up our current environment, identifying our desired state, and then building all of our strategies right in the middle around change. It's our expectation that that change effort will move us toward the desired state for the children and youth of this city. We're excited about it and hope you'll join us in that. And so in that way, I want to invite you to go to the New Orleans Youth Master Plan, the NOLAYouthMasterPlan.org, and take a look at that plan, phases 1 and 2. We offer you a space there where you can join us. You can join us in a host of ways. You can join us by sharing the vision. Vision is all there. You can join us by signing a commitment letter saying that you're in it with us. After you've looked it over, you align and would like to make sure you're committed with us. You can invite us to come and share a presentation with you that gives you much more detail about what the plan is. and you can come and celebrate and get involved in the implementation, because this work is beginning. The creation was one step, but the deep work that requires all members of the team to come to the table is implementing the action on the ground that young people need to experience from birth to 24 is where we need help. So if you find that to be of your interest, I welcome you to that space at nolayouthmasterplan.org. One last thing to offer you. So this is the conversation about the child mental health crisis. We believe that this conversation is critically important to galvanize folks around moving work forward. We are inviting a next part. And so we've been required, named, recommending that the summit for Call to Care that we hosted at the launch of Call to Care, that we have another summit. The pandemic took that away from us in the last year. We are back on it for this year. It is October 26th. We expect to pick up this conversation and leverage what the Children's Hospital has put forward there. You can find out more about that. In fact, we're seeking folks to present at that conference. We are also asking folks to complete a survey that allows us to lay out the continuum. We believe that a built-out continuum can tell the story of how we need to lift up and move change forward. We're using that platform and space to create the continuum, edit it, and to sharpen it, look for ways to build it better. So at the New Orleans PACE Connection site, we would ask you to go take a look at New Orleans ACEs Connection. That is our site for all things trauma, childhood, trauma-related, ACEs Connection related. We are there naming the conference, providing a summit, save the date space, and also inviting you to take a look at the RFP. If you have an interest in participating as a panelist, as a guest speaker, we welcome you in that space, and certainly push the survey button. Let us know about your sight and view of the continuum. We'll be pulling that information together in advance of the summit, and we'll use the summit to work on its final build-out. So I would say to you that the condition of child mental health in New Orleans presents an opportunity for us. So while we are in crisis, our work is not done. We are not done. We should not call crisis our quit button. It is our startup. We get to, at this point, really look at what is necessary to be a place that can say all the children are well. And if we can do that together, because we can't do it in a silo anymore, if we can do that together, then what we get out of this deal is a better child mental health space in New Orleans for the children and youth of this community. What we get is all the warriors of this community, many of whom are here, virtually are in this room, that they can greet each other with the question, how are the children? And the answer, you could proudly say, almost well. We're getting well. We're working on well, and we are all well, is our end run. So I'm going to stop there and thank you for the opportunity to share just a bit. Invite you to go over to the website to see more. If you need more information, I'm happy to make that available to you. And again, my name is Karen Evans with the New Orleans Children and Youth Planning Board. I ask you to do one thing as a wrap-up: wear your mask, get vaccinated, and encourage others to do the same. Thank you all.
Thank you so much, Karen. Your presence, your passion, your leadership today, sharing that with us and with the city of New Orleans every day. Very much appreciated. I'm particularly excited to see what develops with that youth master plan. Really great stuff. So for those of you who are joining us here today and those on the live stream, please hang with us. We're going to go to a quick video that hits on that 1 in 5 theme that Karen mentioned, and we'll resume with our program right after that.
Today, 1 in 5 children are affected by mental and behavioral health disorders, but less than half receive the help they need. At Children's Hospital, New Orleans, we're on a mission to change that. By expanding access, spreading kindness, and sharing resources, we're building a community that gives all children the specialized care and support they need. We strive so that 5 out of 5 children can thrive. Why do you high five?
All right, welcome back, everyone. We've heard a little bit today about the impacts of COVID-19 and the way it's impacting mental and behavioral health, especially in kids. It's my privilege to introduce Dr. Mary Lindell. She's the service line chief for behavioral health here at Children's Hospital New Orleans, and she'll be making some remarks regarding the mental health impacts of COVID-19, something that we know is weighing heavily on all of us, especially through this concerning surge of the Delta variant. Dr. Dell, thanks for joining us today.
Thank you very much. It is my privilege to represent the wonderful group of people that I work with, have the privilege to work with in the Chinola Behavioral Health Department. Other psychiatrists, nurses, psychologists, social workers, therapists of many ilks. Child and adolescent psychiatry historically has been a leader in multidisciplinary work. You've heard from so many others this morning the statistics, the need, the talk about social determinants of health. What I know is that there are many in multiple disciplines attending today, maybe even some parents, grandparents who are listening. And we throw a lot of these terms around, such as depression, clinical depression, mental health, anxiety. What exactly is that? We kind of know, but I'm going to get kind of down and dirty. And I invite you not only to think about diagnostic criteria or specific diagnosis. Those are absolutely necessary. I want to invite us to think about target symptoms or specific expressions, the variety of expressions of these disorders. That is very helpful in terms of all the people in the lives of children recognizing early on good times, helpful times to think about intervening or assessing or even just touching base with kids to say, hey, are you doing okay? Let me touch base with you and give them the message that it's okay to talk about these things and initiate a conversation from child, adolescent, back to an adult or concerned other. So what is depression? It's a conglomeration of things. Again, I want to think about expressions of this, symptoms, sad mood, loss of interest or pleasure, irritability, sleep disturbances, appetite disturbances, physical agitation, or maybe a slowed down kind of feeling in physical activity levels, fatigue, low energy, difficulty concentrating or making decisions, excessive guilt, and these feelings of hopelessness, worthlessness, helplessness. We've seen an increase of that during the pandemic. Thoughts of wanting to be dead, thoughts of hurting themselves, carrying it out. Depressive symptoms are also discussed in terms of other terms like mood disorder. And then we also hear talk about manic depression, bipolar disorder. It's very common, for instance, for a grandmother caring for a child to come in and say, hey, my grandmother acted just like this. I'm concerned. Anxiety, what do we mean by that? That's kind of one of those terms also that we use commonly. I'm worried, I'm anxious. And then there's anxiety that rises to the level of needing professional attention. So it's persistent and excessive worry, on edge, feeling revved up, difficulty concentrating, fatigue, difficulty sleeping, excessive fears, social anxiety, more than usual, and perhaps even more than what I'm experiencing right now, unhealthy avoidance of a distressing situation, panic attacks, physical symptoms such as stomach aches, chest pain, headaches, excessive perspiration. Anxiety is actually the most common condition in children and adolescents. Related to that may be acute stress disorder or post-traumatic stress disorder, and that's already been mentioned today. Exposure to a traumatic event or knowing about a trauma or traumatic event that's happened to a family member or a close friend, intrusive memories, distressing dreams, physiological bodily distress, emotional numbing, and avoidance. And we're going to hear more about that with Dr. Caplo. Now, there are a number of other expressions of psychiatric or mental health concerns too that we need to be aware of. Many of these, actually, as Ms. Evans mentioned, were with us long before COVID, and again, we didn't have enough people to always recognize and treat those before. So if you can imagine these vulnerable populations, and then you superimpose COVID-19, medical illness, psychiatric illness, all the social determinants of health on top of that, again, we need to be mindful of some other problems, some other concerns that our kids are bringing in to COVID. So what about our family and friends, our loved ones, our students who are autistic? In 2020, the estimate was that from the Centers for Disease Control, that 1 in 54 8-year-olds had signs or symptoms of autism spectrum disorder. So if you can imagine with COVID then, interruption in school, changes in routines, changes in dependable caregivers, treatment modalities, not being able to get to appointments, pharmacies closed for a while, so unable to get the next refill. How are those kids interpreting the changes around them? The sensory considerations associated with masking. Also the delay in diagnosis and in treatment that's connecting these group of kids with early intervention. It also applies to all kinds of intellectual disabilities not accompanied by autism. Another vulnerable group, the medically ill. I've focused my clinical career taking care of the psychiatric needs of medically ill individuals. So kids in the ICU with very serious illnesses, delirium, depression, secondary to medications that they may need for their medical illnesses. So follow-up medical care, follow-up psychiatric care, those have also affected this population that was immensely vulnerable even before COVID. Another thing that we should be aware of are those folks suffering from eating disorders. We actually have seen a rise in symptoms of eating disorders. And if you think about it, it makes sense. COVID, decreased physical activity for a lot of times, the increased stress, lack of supervision leading to poor diets, more eaten as part of the poor diet, so increased volume. And then increased body image concerns as these kids think about going back and seeing friends, being back in school that they haven't seen for the last year. Also, when you think about it, our kids who are experiencing any kind of physical, sexual, and emotional abuse. Everyone around them is more stressed. The other thing is that they have had, during COVID, many kids have had less contact with mandated reporters. School, they aren't spending as much time in their activities with religious institutions. So we need to be mindful of that and the role that increased abuse or continued even low-grade abuse, if there is such a thing, may have on kids' emotional health at this point in COVID. Substance use. There's the most recent data out that showed that actually the cannabis, the marijuana, the rates of marijuana abuse, the rates of abuse and the amount hasn't changed during COVID. So what does that tell you? People are still able to get the supply. It may not, it's of varying concerning qualities. And data about other substances of abuse is basically all around the map. So that's to be determined about how that's going to play out. But I think it's critical. We have to pay attention to substance use and abuse. Bullying has already been mentioned. And one population that's been exquisitely sensitive to that has been the sexual and gender minority youth. They are at increased risk, and they especially self-report the value of groups, the connection with supportive people, with peers, with supportive adults, connections in places where their mental health needs can be identified and they can initiate requests. COVID has turned those opportunities upside down for this group of people. We've mentioned youth in detention and in the legal system. I've had individuals tell me that in the course of maybe 2 months, they've lost 2 siblings to violence. Then they lost their great-grandmother who was taking care of them after their grandmother died of COVID. So problems compounding on each other. There's not one single problem, one single category. They are all often, too often, interconnected and additive. Another population that's been mentioned, if you notice, we're not talking about children and adolescents from birth to 18. We're talking about children and adolescents from 18 or from birth all the way to 24. And that's been a relatively recent change. Before COVID, we were hearing a lot more in pediatrics and in psychiatry and psychology about college mental health, which yes, it is college mental health in terms of young adults, but I think a bit of a misnomer because we also, as professionals and as the adults in caring communities, need to be attuned to the mental health needs of those who maybe drop out of high school but are working or trying to get a job. Maybe they are trying to train, hoping to train in a non-academic vocation. These folks, if they have no acute medical or psychiatric problems that necessitate a trip to the emergency room, they have been left out, and we need to figure out a way, partnering from pediatrics to internal medicine, partnering from child and adolescent mental health professionals to our colleagues who are caring for adults. We've got to pay attention to that bridge. And then, of course, it's been mentioned, suicide as the greatest side effect, so to speak, of all these conditions, the most serious outcome. June 18th, the Morbidity and Mortality Weekly Report cited May 2020 emergency room visits, an increase in May 2020 ED visits for suicide. It increased really dramatically for 12 to 15-year-olds. In March of 2021, it was 50% higher for adolescent girls than it was just 2 years ago in 2019. What does that tell us? It tells us that, again, we need to pay attention to some of these very granular, very specific signs and symptoms of depression and anxiety to be able to intervene early. And it also tells us that we need to pay attention to other diagnostic categories, other signs and symptoms, in addition to those that we are casting the nets most broadly for depression, anxiety, post-traumatic stress disorder, and suicide. So, approaches to this. Something that I refer to as clinical pearls or bullet points that I throw out there regularly in multidisciplinary treatment team meetings. Think multi-generationally. That's the strength of a multidisciplinary community focus. Yes, we're focused on children, we're focused on adolescents, but they come with aunts, uncles, grandparents, with aunties, with people who are really good family friends, who are really functionally family members. Who has the best knowledge of any single child we're working with, we're trying to help? It may be the high school baseball coach who took care or who coached 3 older brothers. It might be the family's clergy person who knows exactly what really killed or what really bothered several relatives in their 60s and 70s that may hold the keys to biological, medical, family histories, psychiatric, behaviorally, for the identified child or adolescent. And again, the attention to social determinants of health, substance use, unemployment, family histories, medical comorbidities, isolation, and loss. And we can't say it enough, we have to take the assessment and care, whether formal or informal, to where the kids are. So the schools, into the communities, into the faith communities. We also have to make sure that we don't leave anyone out. We really have to focus on the effects of all kids, on lost opportunities. It's not just kids that fit the traditional social determinants of health. It's those who feel a loss for what they might have achieved, okay? So the kids that missed a football season and were hoping for that year for a football scholarship, the kids that couldn't start a musical instrument, all rites of passage, whether it be missing your bar bat mitzvah at age 12, first communions, all socioeconomic groups. Having money doesn't necessarily buy you mental health care in the day of COVID. Multidisciplinary care, again, is essential. We have to model that for others. That means that even as we are trying to do the greatest good for the most people, we have to remember to we can't forget our trainees. We have to invite more people to learn those skills. Recruitment and modeling professionalism and the intangible rewards of that, model those gifts and graces to others, and we will have other people increasingly working along with us. Keep up with the best practices. Data is coming out increasingly. It may surprise us. When the data contradict themselves, that's when we get in and we dig in and we use the training that we have gained, and we share that in a way that can be understood by others. 2 last things. Yes, we have to be focused on problems, on concerns, on deficits, on diagnoses, on illness. But we cannot forget to look for the hope and the resilience that we see. It is really inspiring in this. That's the talk that I would rather be giving. If we do not look for that, we are also failing in one of our most important roles as a medical provider, as a psychiatric provider, as a nurse, as an educator, as a coach, as a pastor. Hope and resilience, and then you reinforce it. And so whatever that takes, that can be very individual for a child, individual for a family, for a community, but we've got to remember that. The other thing, the last thing that I'll say is that my students and trainees will laugh at this, but as I, in my career, have been in and out of thousands of emergency rooms and intensive care rooms, and you're working with, you're being with, you're present in every way with caregivers. There is often a feeling of powerlessness, of what can I do, what should I have done? And often it comes down to just the simple thing, the best thing you can do for your child is to take good care of yourself. So that is something with our multi-generational care we really need to get out there and reinforce with the families of those that are living day to day with the kids that we serve. We see them for a snapshot. Our families are with them. Their teachers are with them as a running video. And that also applies to us as well. If we can do all that, if we can know the pathology, so to speak, know what the problems are, know what we need to do, what we hope to do, what we aspire to do professionally, and then pay attention to the hope, the resilience, and taking care of the people who take care of the kids, I think we'll be all a lot better off, and hopefully we'll have additional aspects of this conversation that we can share when we meet again.
Thank you, Dr. Dell. We certainly have a lot of work ahead of us. Your comments about hope and resilience really resonate with me. I think I love the idea of focusing on that and leveraging the strength that our young people have in our community. Moving right along, I'm very happy to introduce Dr. Julie Caplo. Dr. Caplo is a licensed clinical psychologist, board certified in clinical child and adolescent psychology. She's joining us today from the Trauma and Grief Center, housed at the Hackett Center for Mental Health in Houston. So we're really thrilled to have her with us in New Orleans today. She specializes in trauma and grief. Dr. Caplo, welcome.
Thank you so much, and I'm really, truly honored to be here with this amazing panel of speakers and organizations. And so today I'm going to be talking about something that I think we can all agree is an incredibly relevant and important topic, which is trauma and grief, particularly in the context of the pandemic. So first, I just want to give you a little bit of background about what we do at the Trauma and Grief Center at the Hackett Center. So the Hackett Center is a policy and research think tank in Houston, and we have 4 main mission areas within the Trauma and Grief Center there. The first is to develop and implement evidence-based assessment and interventions for kids ages 7 to 21 who've experienced traumas or losses. We also conduct research looking carefully at how kids respond to trauma and loss over time, and what can we do to help them over time, especially looking at the effectiveness of the treatments that we're using. We also provide training and professional education in trauma and grief-related topics and interventions to both school and community-based clinicians, and I'm going to tell you a little more about that. And we also try our best to translate trauma and bereavement-informed best practices into policy. So what do we mean by that? We mean that all kids who've experienced a trauma or a loss deserve the best practice care that they can receive. And so we're really trying to do our best to advocate for all kids across the country to receive that best practice care. So I know that many of us have ideas in our head of what a trauma is, but just to make sure that we're all on the same page, when we talk about trauma, what we're talking about is an exceptional experience in which a terrifying or extremely upsetting event overwhelms a person's capacity to cope. And we know that there can be acute traumas like we've heard about, so things like hurricanes or accidents or the death of a loved one. But there can also be chronic traumas that many youth in our underserved communities are going through right this moment. So domestic violence, community violence, ongoing abuse. And we know that sadly, many kids will experience both of these types of traumas at the very same time. In fact, half of US children will experience a traumatic event over the course of their lives. That equates to about 35 million children nationwide, and this number was derived before COVID. So as Dr. Dell mentioned, we need to really be thinking about what this might look like currently. So how do children typically respond to a trauma? One of the most common responses to trauma is what I'm sure many of you have heard of, post-traumatic stress disorder. And in fact, we often say that PTSD is a normal response to an abnormal event. But what's tricky about working with children who've experienced trauma is that it's often very difficult to identify symptoms of post-traumatic stress in kids. And the reason for that is because it can look like all kinds of different psychological outcomes. So for example, kids with PTSD may look like they have anxiety. They often worry something bad might happen to someone else in my family or to myself again. It can resemble ADHD. So we know that kids with PTSD are often very hypervigilant, and that can translate into looking like hyperactivity in the classroom when they look jumpy or on edge. Kids with PTSD are also often avoidant. That's one of the key symptoms, and that can look like distractibility in the classroom. And I would say that about 95% of the kids that are referred to us, and that's not an exaggeration, have already been diagnosed with ADHD. And then when we chip away and really try to figure out what's going on, oftentimes those kids actually had PTSD, not ADHD. It can also resemble conduct problems, and we hear this from teachers all the time, where kids will be running around dysregulated in the classroom. But if we're not asking the right questions, that can look like oppositional defiant disorder or conduct disorder. But oftentimes this is a manifestation of PTSD. A child may be triggered in the classroom by being reminded of the terrible event that just happened to them, and they may be up out of their seat running around because they're dysregulated from that reminder. So what we're trying to do is encourage educators to think carefully about the questions they're asking. So not thinking so much about what's wrong with this child, but what happened to this child. In addition, we know that PTSD can look like physical illness. We hear from our pediatricians that some children come in time and time again with headaches or stomach aches, and they can't really figure out the root cause. But when they ask the right questions, oftentimes that is the PTSD manifesting physically. And this tends to occur in kids who are more avoidant, who are not talking about or thinking about what happened. So what happens to children if we don't intervene after a trauma? We know that there can be some very serious long-term problem outcomes for those kids. And in fact, we know that chronic trauma results in smaller brain volumes. It can result in depression, suicide risk, school problems, problems with peers, substance abuse, violent behavior, and even the intergenerational transmission of trauma or post-traumatic stress. And what's really important to emphasize here is that some of our most significant societal problems today, including domestic violence, community violence, school shootings, stem from unresolved childhood trauma. So think about what kind of world we might be able to live in if we can actually intervene early and keep those kids on a normal, healthy developmental trajectory. So now I want to just turn to a very specific form of trauma that is, of course, becoming more and more relevant as a result of the pandemic, and that is bereavement. So again, to make sure we all are on the same page, bereavement is the experience of deprivation or loss by death, and grief is the psychological or behavioral response that arises from that bereavement. And why are we focusing on bereavement? So you'll notice that I referred to us as the Trauma and Grief Center, not just the Trauma Center. And the reason bereavement is so important is because it's actually the most frequently reported type of trauma in clinic-referred youth across the country. It's the most common form of trauma worldwide. It is the most distressing form of trauma among adults and youth in the general population. So if you were to ask anybody, what is the hardest thing that's ever happened to you, the vast majority would say it was the death of so-and-so. It's also the strongest predictor of poor school outcomes above and beyond any other form of trauma. So one of my former postdoctoral fellows, Ben Osterhoff, conducted a really interesting study of 14,000 students across the country. And what he found is that the sudden death of a loved one was actually the strongest predictor of poor school grades, school dropout, school truancy, lack of school connectedness, above and beyond any other form of trauma, and that included sexual abuse, physical abuse, witnessing domestic violence. So why is this important? This is so important because oftentimes educators are not aware that a child has experienced a loss, and we need to make sure that they do have that awareness. This is particularly relevant for youth of color due to their higher rates of COVID-related deaths. We know that our youth of color have been much more adversely impacted, and in addition to that, their higher rates of exposure to violent death. So those sudden losses are occurring more in certain segments of the population, and we need to be highly attuned to that in order to intervene early. It's also important to not only think about bereavement, but grief. So as I said before, grief is a child's reaction to the death. And what does grief look like in children? How do we know if a child's grief is healthy and adaptive or unhealthy and maladaptive? I've had the honor of working with a couple of colleagues over the last really decade at UCLA, Bob Pynus and Chris Lane, to really research this topic and better understand what grief does look like in kids. And what we've concluded from our research is that grief is multidimensional, and in fact, it's three-dimensional. So there are three very specific bereavement-related challenges that kids often experience. And the first is separation distress. That is yearning and longing for the person who died. The second is existential or identity distress. This is feeling lost without the person. So how am I going to get through life without this person? And the third is circumstance-related distress. And this is being very preoccupied with the way the person died. So things like, I wish I could have intervened, or I wish they didn't have to suffer so much. But what we also know is that each of these challenges has an adaptive counterpart. So with separation distress, I have an example of this. I was working with a young girl, a 9-year-old, who lost her mother, and her mother was her best friend. So she was obviously devastated. And one of the things that we did together in our work was we found ways to help her feel connected to mom in a different but a healthy way. So for example, she started to make her mom's favorite apple pie. She started to take swim lessons because that was something that she really enjoyed doing with mom. And the more that she engaged in these behaviors, the more that she began to feel connected. So that would be the adaptive side of separation distress. With existential or identity distress, we hear from kids all the time saying things like, I don't know how I'm going to get through life without my dad here. But we also hear them saying things like, I want to live the kind of life my dad would have wanted me to live, or I want to do things that would have made my dad proud of me. And with circumstance-related distress, we see this all the time where kids will naturally gravitate toward the circumstances of the death to change those into something meaningful that can help others. So for example, I was working with a 10-year-old little boy whose father died in a tragic plane crash. And when I asked him, what do you want to be when you grow up? He said, I want to be an engineer so I can make planes that don't break anymore. And we hear other things from kids, like, I want to raise money for breast cancer. My mom died of breast cancer. Or, even things like Mothers Against Drunk Driving, or even seat belts, or, fire exits. These all come from tragedies that harmed people, and their loved ones did something about it to ensure that the same thing didn't happen to other people. Those are the kinds of things that we really want to harness in the treatments that we use when we're working with grieving children. And why is this dimensional approach important? Why is this an important way to look at it? What we know is that one-size-fits-all grief treatments are not effective. And the reason for that is because kids grieve in different ways. So a child may be high in separation distress and low in circumstance-related distress. And the way we go about supporting those kids has to look different. So we need to ensure that our treatments are really tailored to the needs of the kids that we're seeing. So the pandemic has raised lots of concerns among educators and school personnel in that they recognize that many students across the country are going to be returning to school having lost a loved one or even more than one loved one. So what can educators do? So some of the things that we've really been talking about with our educators is acknowledging the loss. We know that oftentimes we hear from teachers, I don't know if I should say anything. This child's coming back to school and I know his brother died, but I don't know whether to mention it. The answer is absolutely mention it. So we know that kids feel validated when that is acknowledged, when there's a loss that has been acknowledged. We also want to give words to express support. So just as adults struggle with the right thing to say after a death, We want to help the teachers understand what are some things that you can tell other students to say to support their peer who's returning to school. So things like, I'm so sorry for your loss, or I'm here for you if you need me. We also want to teach them what not to say. So things like, well, I'm sure you'll be over it within a year, or your dad's in a better place now. Those are things that are not so helpful. So really helping educators to understand what they can do to support the classroom to be a more grief-informed classroom. We also want to help them anticipate loss or trauma reminders that might come up in the classroom. Even something as simple as sending parent permission slips home if a child has lost a parent, or preparing Mother's Day cards for Mother's Day. How can we help teachers acknowledge that this is going to be very painful for some of their students, and how can they prepare them? We do, of course, want to recognize the adaptive side of grief. We don't want to over-pathologize because we know that grief is a normal part of life. And the bottom line is that most kids who experience a death will go on to lead a healthy, happy, productive life. But teachers are in the very unique position of identifying kids as early as possible who are truly stuck in their grief. So we want to give the teachers tools to identify who those kids are and ensure that they can make those appropriate referrals when necessary. The pandemic has also raised significant concerns among school-based clinicians or school counselors, many of whom have not had training in how to address trauma and grief in the classroom or in schools. So what can school-based clinicians do? One of the initiatives that we've been working on for the last few years with the support of Robert Wood Johnson Foundation and the New York Life Foundation is called Learning Collaboratives, and many of you have heard that term, but our Learning Collaboratives focus on a particular intervention called trauma and grief component therapy. When we hold a learning collaborative, we bring together 60 to 80 clinicians at any given point in time. We train them for 2 days, and then we send them out into the communities and schools to do the work while providing ongoing supervision and consultation for a full year. What that does is that it empowers the school-based clinicians to be able to feel comfortable with the treatment, to troubleshoot obstacles with us. It also enhances fidelity and sustainability. And with a more recent grant from the Annie Casey Foundation, we have the opportunity to train even more school-based clinicians across the country, many of whom desperately need this kind of training. The treatment that I'm talking about, trauma and grief component therapy, is unique in that it can be tailorized for different populations of students. So the first module is really about just basic coping skills and emotion regulation skills, and can be more of a universal preventive intervention. The second module is focusing on trauma processing for those kids who've experienced trauma. The third is grief processing, and this is where we want to reduce those more maladaptive grief reactions and enhance those adaptive grief reactions. And the fourth is getting back onto a normal developmental trajectory. How do we ensure that kids have goals? We know that for so many of our kids who've experienced multiple traumas and losses, they feel like victims in life. They're not sure how to get back on track. And so this fourth module is really what helps to do that. And so the beauty of this is that the school-based clinicians can choose which modules they use with the students that they see in their classroom or in their schools. So what can we, and when I say we, meaning Children's Hospital New Orleans, do? What we can do is that we can ensure that all children who experience a traumatic event or the death of a loved one receive the support and best practice care that they need and deserve. And how do we do that? Excuse me. Well, the way we do that is that I am pleased to announce that we are going to be launching our very own Trauma and Grief Center here at Chinola this fall, where we will provide evidence-based trauma and grief-informed assessments and interventions to youth ages 7 and up within our own hospital. We will serve as a resource for children receiving treatment in the hospital as well as children in the community. And we will commit, as we always do, to using measurement-based care, meaning that we are going to carefully measure the effectiveness of our interventions to ensure that patients are getting better. We'll serve as a training site for both our Tulane and LSU trainees in order to educate them in how to implement evidence-based assessment and treatment. And we know that the need is great and that we can't do this alone. And so we plan to partner with many of the organizations that you've heard from and are going to be hearing from today to ensure that we're reaching at-risk youth where they are most likely to be identified, whether in the schools or after-school programs or pediatric offices. And we will continue to provide training to community and school-based clinicians across the country, but also in New Orleans, to empower them to offer the very same evidence-based practices that we do, because again, we know the need is so great. So this opportunity to build a TAG center could not have come at a more critical time when so many youth across New Orleans are suffering from trauma and losses on a daily basis. And before I end, I just want to thank John Nickens in particular for his wisdom and support and dedication to this incredibly important issue, and I, for one, cannot wait to get started.
Test. All right. Thank you so much, Dr. Caplo. That's incredibly exciting. We're thrilled to be launching this project with you in a few short weeks. It's going to be fantastic. Before we move on to our next segment, our final panel of the afternoon, we're going to take a quick break. So please enjoy this short video.
At Children's Hospital New Orleans, we're committed to healing sick children. But it's more than that. It's the idea of getting outside of the hospital and creating environments of health. It's the idea that we can change a generation. Health outcomes today for the kids of Louisiana aren't great, and we want to be a part of the solution. That's what Thrive Kids is all about. Children's Hospital is making a significant investment into school wellness. This is an opportunity and an honor for us to partner and work with schools across the state of Louisiana.
Thrive Kids is a program that optimizes each school's needs for their children, and really it's to promote the mental and physical well-being for each kid within that system. We're trying to do this in an engaging and innovative way so that they really buy in to their overall well-being as well.
By connecting our pediatric health experts, as well as our Louisiana educational experts, we are ensuring a healthier future for our children. Thrive Kids provides school-based virtual care, mental and behavioral health services, sports medicine, chronic condition management, a dedicated nurse hotline for school wellness and virtual care, and education and resources for schools. We will also be there for our schools when the unexpected happens. During the COVID-19 pandemic, we partnered with the Louisiana Department of Education and schools across the state to ensure that both the students and our educators had what they needed to safely return to school.
Collaboration between our education and healthcare communities with a shared vision to help all our students thrive, it's critical. In some of our communities where services like medical and behavioral health care may be difficult to access, students and families will benefit from this type of partnership to best reach our kids where they are in our schools.
It's really important that we bring healthcare services into the school setting because attendance. Our kids need to be in school as much as possible. Having that access to services in the schools can really, really significantly improve students' attendance, and ultimately that improves their long-term outcomes academically. Children's has also been a great partner in providing physicals for sports, getting our kids a quicker access to the proper care that they need.
Children's Hospital has been the resource I never knew I needed. Their ability to answer our questions, connect with our medical advisors, help guide our procedures, and just knowing that I have a resource has given me, and I know my leadership, a lot of peace of mind as well.
As a mom and a pediatrician, I'm inspired by the progress we are making together with our school partners to advance the health of our students in Louisiana.
We can make a generational change for not only the schools but the kids, and hopefully that'll continue their health education and their health care and their emphasis on themselves later in their lives.
Bringing services directly to schools will help all of our young people have the opportunities to learn and grow and be healthy.
Working with schools across the state of Louisiana, the future is bright for our next generation. This is how we can be extraordinary together. Thrive Kids, the student wellness project by Children's Hospital.
All right. Welcome back, everyone. Extremely excited for this final panel of the afternoon. For those of you that are joining us on the live stream, as you can see, an incredible amount of ground we're covering today, so we probably will run past our intended stop time at 1 o'clock, but again, I think it's important to keep this conversation going with so many great leaders here with us today. Very excited about this panel. We have a lot of partners from across the community, including our academic partners at LSU and Tulane. So thrilled to have you all here with us today. Rather than starting off with introductions, we'll kind of do introductions as we go along. Dr. Zena, you drew the short straw, so you're going to get to go first. Dr. Zena is the head of child psychiatry at Tulane University School of Medicine. Dr. Zena, I know a big focus of your practice and your passion has been collaboration with primary care physicians in the community. What are some of the things that we can do to assist our primary care providers with identifying and assisting with behavioral health needs?
Well, I would say a couple of things. First is I was very heartened to hear Dr. Hussey mention the importance of early childhood, and to hear my friend Karen Evans, who has crafted the master plan in a way that begins at birth. We can talk about whether that's soon enough, but at least that's an important step for this community. And a lot of consultation to primary care involves trying to identify problems in young children before they become as entrenched and difficult to treat as they will later on. So much easier to get a 15-month-old on a healthy developmental trajectory than to get a 15-year-old who spent many years struggling on a healthy developmental trajectory. So we don't want to abandon the 15-year-old by any stretch, but we also want to invest in early childhood consultation. The problem we've had is it's been supported by soft money for about 7 or 8 years, as long as we've been doing it. We need really statewide investment in this kind of approach, and not just to, we don't just do consultation of primary care, but also to early care and education, to the Department of Children and Family Services, to all of the areas that encounter young children who are the children that we need to be caring for.
Great, thanks very much. I know screening and detection is a big issue for primary care physicians. Any tips or best practices you'd share about screening and detection in that setting?
Well, there's some really good measures for purposes of screening and detection that are available. But one of the things that we've tried to do in our effort is not just help primary care providers identify, but also be able to manage mild to moderate level problems, because there are just not enough mental health professionals to meet the need. And so it's a matter not just of integrated care, but also really trying to enable primary care providers to be able to handle things that oftentimes they're not well prepared to handle based on their training experiences.
Thanks very much. One of the great community resources we have here in New Orleans is the Children's Bureau. We're thrilled to have Dr. Charlotte Cunliffe, President and CEO of the Children's Bureau, here with us today. Next question's for you. Tell us a little bit about what the Children's Bureau does and the resources it offers to the community.
Yes, thank you. Thank you for having us today. Children's Bureau has been around since 1892, and we've spent the last 30 years really focusing on being a community-based, evidence-based practice around mental health counseling for really children, youth, and their families. We work with children between the ages of 5 and 24. Can't get to early childhood, Dr. Zena, but we look to partner on that. And so we are unfortunately one of those of the few freestanding mental health agencies, and many of you know that as we've moved into Medicaid and other funding sources, it's been there's a lot of money out there. Unfortunately, they haven't really funded evidence-based practices at a community-based level. So the funding isn't very adequate. So just like Dr. Zena was saying, we're on soft money, and so we work to try to get services out, but we're really have been looking to partner with places like Children's Hospital and others so that we're not having to look so hard for referrals, and we can work as part of a larger system Because historically, we've been one of many people going to schools and knocking on doors and saying, can we see your kids? Can we see your kids? You know, we're in juvenile courts. We're all putting ourselves in places where we can see these kids and it might be easiest for them, but that makes it really confusing for the community. So as a community-based provider, I hope that we can partner more closely and create that system you had mentioned that will make it easier for parents and everybody to find the services.
Thanks very much. I asked Dr. Zena about screening and early detection. I'll give you a question about that too. There's been some suggestion that if we had a universal program led by the city or a citywide effort, that could be really valuable for our community. What are your thoughts about some sort of universal screening program in our schools?
I think that anything we can do to create a common approach for people to understand what's needed, how to find the right levels of care. A number of years ago, I worked at Metropolitan Services District, and we tried to create a single point of entry, but it was primarily to allow people not to have to, what I call, be part of it's like a pinball machine is what we do to people in this community. You know, hey, you don't know what you need, we'll just pop you out there, you bounce around between all of us providers, and you're unable to know it. And so, to me, whether it's universal screening in schools as a mechanism, whether managed care does a better job of coming up with, some level of standard assessments, but it's really about the community, I think, coming together, agreeing. I'm not clinical, but agreeing on what the needs are, what are the levels of care that are appropriate, and then trying to figure out how we do that. But we have to uncomplicate this to increase access, is the way I'd put it.
Thanks very much. Next up, thrilled to have Dr. Lakeisha Mammon here with us today. She's the chief of the Division of Child and Adolescent Psychiatry at LSU Health New Orleans. Dr. Mammon, one of the things we talk about here at Children's a lot, we're really proud of the fact that we take care of all children. And we know that mental health impacts all children as well, including children with special needs. Any thoughts on particular ways that we can address mental and behavioral health in the population of kids with disabilities and special needs?
Yes, this is definitely something that I think about professionally as well as personally. I'm a mom of a moderate autistic child, and so especially during this time, a lot of our families are struggling right now, and it's because of the COVID epidemic and the different loss of resources, of the ability to have their normal caregivers, speech therapists, occupational therapists, ABA therapists come into the homes, come into the schools, and for these children, they really need routine, and they dysregulate a lot when they don't have that routine. And so our children with special needs, whether it's autistic, along the autism spectrum disorder or intellectual disability, they suffer with anxiety, mood disorders, all of the things that typical children would do. And so we have to, it's wonderful to be here with all of these different collaborating agencies. It's fantastic, but a couple of places stick out in my head in terms of where to seek for care. And so we have the autism clinic that's here at Shinola, which is wonderful for assessment and treatment. LSU Behavioral Science Center, we also have treat children from infancy all the way up into adulthood, all right, with the infant mental Harris program, so you can have assessment, treatment, and we have a number of people, whether it's psychiatry, psychology, or social work, to really take care of folks. And I also work with Metropolitan Human Service District, where the intellectual developmental disability clinic and services are organized. And so the best thing that I can tell people is, Ms. Evans said it so beautifully earlier, is that these are lifelong disorders, and so we want to make sure that we get treatment and assessment in early. And so we don't want to wait for an emergency, so call that number and to let families know they're not alone.
Thanks very much. Dr. Mammon, we've heard a lot today about the importance of it's not just the child, let's think about the whole family. We know that we are under-resourced as a community when it comes to mental health. What would you say to those families that are waiting to get mental health services? What are some of the things they can do before they're able to access that care?
100%. We have to take care of the entire family, just not the child, but all of those caregivers that are in the home. So first is, as Dr. Dell mentioned, to make sure that those caregivers are taking care of themselves. They need to make sure that they're seeking treatment. If they're suffering from food instability, housing instability, resources, they need to find that number to call and get those resources. Within the homes, I would like for all caregivers to remember that in a time where we cannot promise, and there's so many changes, that you want to make everything as routine as possible, and that can be as simple as bedtimes, making sure that you're getting up and eating at the same time, spending time together, outside time. So those are some basic things that families can do while they're waiting for that mental health services.
Thank you. We're also thrilled to have many of our schools from our community represented here on the panel today. That includes Edna Metcalf, who's the Executive Director of Health and Social Services at Jefferson Parish Schools. Edna, what are some of the things that Jefferson Parish is doing to support children who are suffering with anxiety, depression, and the host of other mental health issues we heard about today?
So we're hitting at a lot of different angles. Speaking of a universal screener, we do utilize a universal screener that we do twice a year. And that screener detects internalizing as well as externalizing behaviors. Because typically in a school system, everybody picks up on the child who's acting out. But lots of times children don't, people don't pick up on that child that's having more internal problems. So we do that to kind of give us an eye on what are some of the things we need to pick up on. Those children are reviewed, but we have a mental health leadership team in every single school. So those children are reviewed by there, and then they make a decision. Does this child need to be referred to one of our mental health professionals? Do we need to refer this child? We have something called an academic behavior intervention team. Do we need to refer them to them? We have school-based health centers. Do we need to refer them to them? Do we need to refer them to an outside agency? Do we need to do mentoring? It kind of gives us an idea of how do we need to support them. So we are kind of fortunate in Jefferson Parish. In Jefferson Parish, we have 123 highly qualified mental health professionals who service our children in the schools. In addition to that, we have 10 counselors and social workers that work with our English limited learners, so those who don't have the language skills yet. We also have 10 school-based health centers, which, thank goodness, we have a nice support from some of the people in this room. We have connections with Tulane, with LSU, with Ochsner, who support us in our psychiatry and mental health services, as well as Access Health, who helps us with psychiatry, as well as our health services. So we're very lucky in that. We all obviously have our high school counselors who help as much as they can do. And we have social workers that are specialized in trauma-informed practices. We're very happy this year that we're expanding our contract with Children's. We've had a contract with Children's to do telehealth services. This year it's going to expand to include behavioral health, which is going to be a big support for us. We are also able to start a new contract with Children's Hospital, to contract some additional social workers to help us. And our whole idea was, when we refer to outside agencies, right now during this time of COVID, we might refer a child to, I'm not going to name it, some agency. It might take them 6 weeks to see a social worker. It might take 3 months to get a psychiatric appointment. So we thought, we need to do more here. So let's hire some more mental health professionals that could do that intensive weekly therapy and really help the children in combinations with our school-based health centers. Charlie Zeno, who was here a second ago, he helps us a lot out with our psychiatry services, and so does LSU. So we're very pleased with those partnerships. We do a lot of training. Children's Bureau, right over here, has provided training to us in crisis intervention and grief therapy. So we have our own crisis team. So if we have a death in the school, we have some type of serious traumatic event, we send out our own crisis teams, and they're groups of like 10, but sometimes we need 30 of them, depending upon what happened in that school. So we've used their model, and we thank them very much for the training that they've given to us. That helps us support any children who are in some type of crisis. These are just some of the things we try to do to help our children.
Thanks. Thank you very much, Edna. Also joining Edna from Jefferson Parish Schools is A.J. Peth. He's the Chief of Schools for Jefferson Parish Schools. Really appreciate you being with us today. Piggybacking on what we heard from Edna, we certainly know that there are a lot of challenges related to COVID with kids returning to school. What are some of the things you guys are doing to prepare for the new school year? We're anticipating in-person learning and making sure that kids can cope with being back together in that environment.
Thank you for that question. So I want to set the context where we are in Jefferson Parish. So we're a school system of 50,000 students. And when we began the school year last year, we had 20,000 of those students learning at home virtually. Towards the end of the year, we still had 12,000 students learning at home virtually. So we know as we begin the school on Monday, we're going to have kids who have been out of school for a year to a year and a half, and that'll be their first time back in person. So we may have 7th graders who left when schools were shut down, and they'll be back as 9th graders at the high school level. Or 8th graders who left us and are starting as 10th graders, haven't even had a 9th grade experience in person. So we know we have to be very prepared for that. Ms. Metcalf already touched on one of the partnerships we've developed with Children's Hospital, where we're increasing the mental health providers in our schools. You know, 2 things resonated with all the speakers today. One thing was early intervention and prevention, and 2, the need for mental health was always great. Now it's even more great with COVID. So we have a lot of programs in place and supports in place to be able to do that. I want to highlight a few different things where we're trying to early intervene with students. We have a couple of teams that Ms. Metcalf mentioned, one of which is the behavior support team. So we know there's students at every school that experience some difficulties. And there's times when principals are at a point where they don't know what else they can do. So they're able to refer these students out to the behavior and mental health support team, and they're staffed and weekly meetings are held where they can then go into the schools and provide support. And the idea is that we don't have a magic bullet, that we're not just going to come into the schools and all of a sudden the students are fixed. The idea is that we're going to support the school level personnel to be able to identify the issues and work with them to develop a plan for those students and conduct follow-up appointments with those students in those schools as well. So that's one team. Another team we have is the Autism Team. And again, very similar concept. Schools can refer out, and then the teams meet on a weekly basis, and then we're able to go back to the school level and support the personnel at the site. And then the third thing that we really want to emphasize is we provide many trainings. CPI is a training that we offer all of our schools. And there's parts of CPI that there's holds and really restraining kids, but that's not what we focus on. We really focus on the idea that how do you de-escalate? When students are in crisis, how do you de-escalate by using words? And that training is more beneficial than the restraint training that we do. So those are just some ways that we really want to, again, early intervention and support our schools by collaborating at the school level with central office.
Thanks very much, AJ. Incredibly pleased and thrilled with your vision to bring more resources into the school. We think that makes a ton of sense. One of the people doing that is Dominique Burns, a clinical program manager on our team here at Children's Hospital. Dominique, what advice would you give to teachers and parents on their ability to obtain resources?
Sure. It's been a great experience to transition from the classroom to behavioral health. You know, it's always been a great passion of mine to not just advocate for the child, but for the whole family. In doing so, it's so important to understand the gift of collaboration. On the school environment, you have so many resources at hand, particularly the expertise of mental health teams that are there, psychologists, social workers, counselors, in collaboration with those families and those educators. You know, when we step into a classroom, we start to uncover a lot more about that child and their family. So it's utterly important to have those conversations and that collaboration with those mental health teams to see in which ways can we intervene, in which ways can we have those crucial conversations with families, because families might be able to make that next step to say, you know, now is the time to make that appointment with the primary care physician and have them to assess and to refer out. So those strong mental health teams at schools are so vital, and they truly are the frontline workers as well there at the school campus. Children's Hospital, we've done a great job of really ramping up services and partnerships and programs with schools. So I'm so proud to see how much we've been able to engage with schools to partner and to also programmatically change some ways that we can deliver behavioral health services, whether it's through telepsychiatry or medical services, whether that is through virtual care. So primarily, collaboration is key. I want families to know that it's important to collaborate with the school. You know, upon discharge from the hospital, if there is an inpatient stay, it's so important to talk to
those school leaders as well as those classroom teachers, what are those next steps that my child might have missed? And which ways can we ensure that those kids are gonna attend those post-discharge appointments that they have with providers? So it's vitally important to collaborate. Look on our website, we have so many resources, and we will show you guys a little bit more of how to access those resources later on today, but it will guide you and navigate you through where in the community can those needs be met, whether it's at Children's Hospital or with one of our partners here.
Thanks very much, Don. It's my pleasure now to introduce Kevin Gutierrez, Governance Director for Louisiana Association of Public Charter Schools. Kevin, we know that in our school ecosystem, we have a lot of independent organizations working together. What are your thoughts about our ability to create one unified or holistic school front to address some of these needs? Is something like that even possible?
First, yes, I do believe it's possible, and I'm going to back us up just a little bit and thank Karen Evans for starting the conversation around, asking how are the children. And I'll begin by, saying since 2004, graduation rates in New Orleans have moved from 54% to 75%. That means that we've gone from 37% of our students being college, moving into college entry positions to 61%. Yet, New Orleans students experience emotional trauma at 4.5 times the rate of the national average. 4.5 times. 10% of students with behavioral disorders are served outside of the school setting, now nationwide, yet 1/2 of 1% are served in that manner here in New Orleans. Those are staggering percentages and staggering numbers, but also in the face of academic achievement, in the face of possibility, in the face of what our kids in our community can do, certainly says that we can do this as a system of schools. So to answer the question about the system of schools and collaboration, really I think about the data and the fact that meta-analysis of research underscore the effectiveness of making decisions and placing resources as closely to the child as possible. And that's what our system of schools does. We've got differentiated funding for kids at risk. We have significant engagements in terms of trauma-informed practices throughout this COVID experience and beyond. And we have, as we've heard today, many, many more opportunities to engage with one another, to continue to bring practices to the surface so that the myriad of folks that are serving kids, the myriad of governance community, educators who are working really hard can have easy access and understanding to the resources that we've described today. So I would say that, even to the point of 100 yards from here, we've got 51 beds for kids that could be served in this community who need really significant resources. And that didn't exist just a couple of months or a couple of years ago. So we're making headway. We have to work harder to collaborate, certainly, but I think that the opportunity to do so on behalf of the kids and community is at hand.
Thanks very much for those comments, Kevin. Also joining us today is Dr. Liz Williams, who's CEO of another great children's hospital partner, the Center for Resilience. Dr. Williams, we hear a lot about this notion of social emotional curriculum. What role does that play in the school setting?
So I answer this question as someone who has been in schools for most of her career and now sits at the intersection of schools and mental health. But when I think about quality social emotional curriculum, I'm looking for something that does a few things. One, it provides children with opportunities to really build connections with other peers and with adults. Two, it teaches kids vocabulary to talk about and express what they're feeling. One of the challenges with kids who often are diagnosed with or are experiencing behavioral health needs is that their expressive language skills are compromised. We talk about sheltered instructional practices as being a great tool for that reason. So you're helping kids name what they're feeling and understand what they're feeling. And then you're also helping them learn to manage their feelings, right? So how do I deal with the stress that I'm feeling? What are some strategies that can help me resolve this conflict or this emotional reaction that I'm having? And obviously that supports the child, but it also helps educators who may not have deep training in this realm identify kids who have the internalizing behaviors, who are crying, who are withdrawn, who are feeling anxious, as well as the more obvious externalizing behaviors, so kids who may be having outbursts and are explosive, et cetera. I know part of that question was, okay, so what's in place in schools across New Orleans? And obviously Orleans Parish being a completely decentralized system of schools, to Kevin's previous question, means that there's not necessarily a universal approach. There are curricula that meet kind of those hallmarks that I talked about. Second Step is one that you see pretty prevalently. The ruler approach out of Yale University is another one. I think what is a unique challenge, though, is a lot of these curricula that are validated, that are evidence-based, have not necessarily been assessed in communities where you see the high prevalence of need, high concentration of public school population that are children of color. And so I think that's something we need to be thoughtful about. There's one in particular that we have learned about and actually are working with Karen on through University of Pennsylvania. It's called PLAY, Preventing Long-Term Anger and Aggression in Youth. And it was specifically validated and designed for youth, primarily males who are African American, to help build stress management skills, to understand the emotions that they're experiencing, and to deal with racially stressful or other kinds of stressful situations and resolve conflict effectively.
Great. Thanks so much, Dr. Williams. Moving on to our final panelist, we're very honored to welcome Dr. Mary Birch. She's the clinical director for the Children's Bureau here in New Orleans. We've heard a lot about the influx of mental health conditions, particularly in schools today. What are some of the things you would say about how we can assist and comfort elementary and high school students facing some of these challenges?
Sure. I think there is a lot of stress heading back into the school year this year. I am a parent of a 3, 5, and 9-year-old who are headed back to school on Monday. And the past couple of weeks, they've had peers who've been diagnosed with COVID, and man, the questions have been flooding in. And so we have, is it safe to go back to school? What is it going to look like this year? Is it going to be the same as last year? Will it be different? And, even my 3-year-old, we were playing yesterday, and he took my temperature and told me to put my mask on before we did pretend drop off for school. And so, one of the things that I've been thinking about is, how do we talk to kids about heading back into the school year? And I think, for me, I will say the first thing I did was call a trusted friend who's a health provider, and I kind of checked my own anxiety that I have as a parent heading back into school. And I think that's important for the adults in all of the spaces, because I think we all carry some anxiety heading back into school. And so use those supports that you have available to you, but also focus on what do we have control over? What are the routines around safety that we're putting into place? What can we do to keep our friends safe? What are your teachers doing to keep you safe in school? And really focus on those things. And so that has been the message that I've had to my own kids and to my friends who are teachers who are heading back into the classroom.
Great, thank you so much. Well, thank you again to everybody who's joined us today. Those that have joined us on the live stream, you've submitted a ton of great questions that help spark some dialogue today. I think, as we know, this certainly isn't the end of the conversation, but I think this has been an incredible forum to build some connections. As we close out today, I'd like to turn the stage over to Mark Granatza. Mark's the service line administrator for behavioral health here at Children's Hospital New Orleans. Again, as I turn it over to Mark, I want to thank everybody who's here with us, both in person and through the live stream, for your commitment to serve children and deliver a happier, healthier tomorrow. Thanks so much for taking time to join us today. Mark, I'll turn it over to you.
Thank you, Jonathan. And wow, what an incredible session. First off, I'd like to thank Mayor Cantrell, John Nickens. Thank you for your support and leadership in helping to push this initiative further. I'd also like to give a huge shout out to all our panelists and all their support, and not just today, but everything that you do day in and day out to really help solve this crisis. Finally, I'd like to give a shout out to a few people who are not here today, but are 100% dedicated to this mission and have supported us in this cause. The Goldring and Waldenberg Foundation, the Bartholomew family, Roger Ogden, Harry T. Howard III Foundation, These have been crucial members in our success and what we have been able to accomplish in the last few years. You've heard a lot today from all of these experts about COVID-19, about trauma and grief, bereavement, what we can do in our schools, and all these significant things that are impacting our children. The one thing that has reverberated with me the most is not one individual can fix this. It's going to take a community. It's going to take all of us to come together and be extraordinary together to solve this problem. The cities, healthcare, government, everybody, schools, our academic institutions, Tulane, LSU, and your dedication, all of us on this one single goal. Again, we've heard a lot of complex themes. We went in depth on some issues, but I want to close us out with what does this mean to a child? We had a patient who recently told me that all of this is really simple. I just want more good days and less bad. I want more smiles and less frowns. I don't want to have to miss school because I feel bad. That is what we are here today. We are here for our children. So I want to thank all of you again, both here and online, as we strive to make sure that all of our kids thrive. So thank you very much, and I hope you have a great day.